Nā mihi nui kia koutou katoa. Kia ora koutou, ko Richard Blakey toka ingoa, hei ka mai I haha te whare wānanga o Otago. Tēnā koutou, tēnā koutou, tēnā koutou katoa. Good evening, everyone. My name is Richard Blakey. I'm Deputy Vice-Chancellor for Research and Enterprise, standing in for Professor Harleen Hayne, the Vice-Chancellor tonight, who is not able to attend as she has just got back from overseas and was not sure whether the travel plans would get her here in time. She sends her apologies, though. It's my great pleasure to introduce this inaugural professorial lecture for Professor Sarah Derrett to you this evening. And really my job is to introduce not the speaker, but the rationale for having an inaugural professorial lecture, give some overview remarks, and then lead on to Professor Paul Brunton, the Pro-Vice-Chancellor in the Division of Humanities, to introduce Sarah to you. Firstly, welcome to those who have come, in some cases, from afar to be here, in particular to guests of Sarah. Understand your mother, Alison, your sister, Helen, and your niece, Jessica, have travelled from New Plymouth, so welcome to you. And that your friend Sarah has come from Christchurch, so welcome, and I hope that your travel has been safe. Also, your husband, Brian, and son, Micaiah, have travelled from Dunedin, no, actually from Port Chalmers to get here tonight, so welcome to you, and I trust that your journeys back home, either tonight or later, are safe. Acknowledge also the Deputy Vice-Chancellors, Pro-Vice-Chancellors, Deans and Heads of Departments we have here tonight. Visitors from our local community, welcome, and these are public lectures, so welcome, and those of you who are here from our academic community, welcome, welcome, and thrice welcome. Inaugural professorial lectures are a very important part in our academic calendar, particularly for those of us with administrative loads that mean that we crave for the opportunity to get and be intellectually stimulated in our lives that are often overcome by administrivia at times. Or no, I mean very important administrative duties and email. So as much as anything, we preserve and we invest in inaugural professorial lectures for our own benefit, but of course, as well as to allow people who have been appointed to this highest of our academic titles to profess to their colleagues and to members of the public. And becoming a professor at the University of Otago is no mean feat, that either appointment from outside into a named or vacant chair, or in Sarah's case, promotion from within, requires candidates to have demonstrated performance at the highest level across teaching, research and service, the three components that characterise the academic life at the University of Otago. And that is identified with a four-letter acronym, SOLC, Sustained Outstanding Leadership and Competence, that has to be demonstrated in at least two of those three attributes of teaching, research and service, with mere outstanding performance in the third of them. It is not possible to be appointed to a professor at this university by being weak and trading off high performance in one of our core areas with poor performance in another. We value and see the value in supporting teaching, research and service at equal status here. In Sarah's case, look, that and looking through and reviewing the documentation that the Vice-Chancellor had in front of her when she was determining this promotion, I can see that it was a very, very straightforward case. Coming from a humanities background, through nursing to academia and practice, leading units such as the injury prevention unit, leadership that is highly focused, leadership and service that is highly focused towards outcomes and importantly, equitable outcomes for people and communities. Sarah's performance is right on the mark. For me personally, it hits a number of attributes of identifying that we are here not only to train the next generation of practitioners, members of our communities, and outstanding researchers, but through that work that we do, as much as possible, lead to direct benefits for the people that we support as well. I note that Sarah has a a key leadership role in a new and important initiative we have as the Centre for Health Systems and Technologies, which is aimed to strengthen and enhance our translational research profile by looking at supporting New Zealand's first health research strategy that has key strategic goals of both creating a vibrant research environment in the health sector and building and strengthening pathways for translating research findings into policy and practice. And I have no doubt that we will hear some of the work that Sarah has been involved with at the very applied end in her lecture tonight. So with that, I did not have anything to do with this promotion, but I can see that it is very, very well deserved and that it was a very straightforward decision based on the materials that I've reviewed for the Vice-Chancellor to endorse that promotion. So congratulations, Sarah. And I now hand over to Professor Paul Brunton, the Pro-Vice-Chancellor in the Division of Health Sciences, to give you a more formal introduction. Congratulations.
Thank you, Richard. Kia ora, tēnā tātou koutou. My role tonight is to tell you a little bit about Sarah, and to do that effectively, I have obviously looked at her CV today, and I tell you, I could be here all night just summarising the CV, because this is a very accomplished colleague of ours here at the university. But the key points, I think, to allude to are that Sarah graduated with a Bachelor of Arts and a major of History from the University of Otago in 1987. She then went on and qualified in nursing from Otago Polytechnic in 1990, and a master's degree and PhD from the University of Otago closely followed thereafter. Sarah's public health research concentrates on health and disability outcomes, policy and equity, and Richard has already alluded to that. She was a Harkness Fellow from 2011 to 2012 at the University of Chicago, investigating healthcare integration in rural safety net clinics, and is an international Euroqual group member focused on the assessment of health-related quality of life. In tandem with all that, she's deputy head of the Department of Preventive and Social Medicine, where she's also director of the Injury Prevention Research Unit. As such, much as Sarah's research is focused on outcomes for injured New Zealanders, for which she acknowledges Health Research Council funding. And I could go on, but I won't. So at this point, I invite Sarah to come forward to give her lecture entitled Public Health and Communities, People, Power and Policy. Sarah.
Tēnā koutou katoa. I'm just trying to set my timer so I don't keep you here 1 second longer than I ought to. So bear with me. Okay, ready to go. Glasses. So thank you, Professor Blakey, Professor Blunton, Pro-Vice-Chancellors, Trish, Head of Department, tēnā koutou katoa, ko Sarah Derrett. I'd like to begin by acknowledging the tangata whenua for their tautoko for my research and career, and particularly the people from Otako, Puketaraki and Moeraki. I'd also like to acknowledge the Pro-Vice-Chancellors, Trish, Professor Sir David Skegg, who's here in the audience, past Vice-Chancellor, and also the person who interviewed me and allowed me to begin my Masters in Public Health Training. Thank you very much for coming. Obviously, my family, my mother Alison, Sister Helen, Jessica, Micaiah, Brian, all of you, Sarah, thank you very much for coming and being here this evening. You've all, been such wonderful supports to me over the years, and Micaiah's partner via letter in recent times, cooking fabulous meals. And Leah Taylor, thank you so much for coming, Leah, who's been a constant and loyal supporter of my career and pathway for many years since my days at the Mornington Methodist Church, so it's lovely to see you here. And everyone else, this is a bit of a treat. There's some faces I haven't seen in a long, long time, and I'm very appreciative of you being here. So my talk's going to begin with a brief introduction to my family background and personal academic pathway via history and nursing to my MPH and PhD. Then I'm going to present a widely used definition of public health, drawing on some examples from my own public health research, to outline how my work and the work of my colleagues links to the subtitle of my talk, People, Power and Policy. So, this is the Lady Nugent, and kia ora, Father. I hope the technology hasn't let us down, but my father can't be here. And I'm going to be talking about my father's ancestors and my mother's ancestors a bit. So the Lady Nugent, it's 1841, coming in on a rather choppy sea to Wellington Harbour. But on board was an ancestor of my mother's, Sarah Studley. And Sarah had come out as a young teen from Devon on the Lady Nugent, and she ended up marrying Joseph McLeavy, who was a member of the 65th English Regiment. He was illiterate, but paid for all 6 children to be educated, including the girls, which was an optional item in those days. So the man Sarah Studley married, Joseph, was part of the 65th York and Lancaster Regiment, or the Hickety Pips as they were known. In my mother's family, the migration began with Sarah, but it continued on mostly with the people coming out from Scotland until 1878, when my great-grandfather Simon Moore came out to New Zealand on his own, leaving his family at the ripe old age of 18 to set up a new life here in New Zealand. Another branch of my mother's family, Thomas and Janet Harrison, immigrated to Port Chalmers on the 4th migrant ship, the Blundell, which brought settlers to found this Presbyterian settlement here in Dunedin. The ship, the Blundell, left London on the 4th of May and arrived in Port Chalmers, New Zealand on the 26th of September, 1848, so a voyage of 148 days. And I reflect often on these ancestors and what took them to these far-flung parts of the world and what their motivations were. I think often, from what we understand, it was a situation of deprivation and need. So I know that Simon Moore, leaving Orkney, left 9 acres of land that was supporting 2 families, including 21 children. So he really needed to go and find his own new place in the world. Quite why he came here and his brother went and settled in Canada, I don't know. Anyway, so the Harrisons came in 1848, and in fact, I think I spotted Paul Hanson here. Paul has ancestors who came on the Blundell as well, and yeah, I don't think so. I've looked into it, Paul. But they set sail with 5 daughters under the age of 10, the Harrisons. But 7 weeks before arriving at their destination, Janet gave birth to her 6th daughter on the 31st of July off the coast of Africa, and I just can't believe what that must have been like. On my father's side, so my father can't be here, but that's a picture of my dad. Richard and Mary Langman came out to New Plymouth with 3 young sons in this instance. Arriving on the Blenheim in 1842, Robert Langman was a miner, and his parents had both died in the cholera epidemic of 1832 and are buried at the Lostwithiel churchyard in Cornwall. He had a mail run into the Whanganui region during the New Zealand Wars, but ended up owning a Red House hotel in New Plymouth and having a number of children. Migration on both sides of the family stopped in the late 1870s. And my moving to sort of more recent times, my early childhood was initially spent in Sanson, then Martin. And then when I was 2, I moved to the remote southern King Country, where my father farmed 5,000 acres, and where my sister and I had an idyllic childhood, really, of horse riding, kayaking, lots and lots of beautiful forest and idyllic beaches. There were no shops whatsoever. And the nearest town was a little metropolis called Waitara, where we went once every 6 weeks for groceries. My parents were highly organised people. The mountain, Taranaki, featured large in our lives. Often what could or couldn't be done on the farm was based on how visible it was. And I believe this is my first trip up to see the snow with my mother, who was looking sensational and great specs. And little sister, my father was behind the camera, being before the days of selfies. So my schooling, getting to contemporary times, was at Whareareno Primary School, where my mother was the sole charge principal of up to 33 pupils, single-handed, ranging from primary, new entrants through to Form 2 students. And my mother's work ethic and enthusiasm for education has inspired us all, and definitely myself. I then went to high school in New Plymouth and came to the University of Otago in 1982 to begin a degree in medicine that I stopped, rightly or wrongly, towards the end of the second year, to complete a degree in history. And then I did my nursing training at Otago Polytech and had my first job in Lenore's ward up at the rehabilitation unit at Wakari Hospital. And it was a fantastic job. And I was mentored by Juliette Manning, who is an absolutely wonderful nurse. And I then moved to work at Ashburn Hall. It's now called Ashburn Clinic. I spent a total of 10 years nursing there, although I began my DPH training throughout that time. And I really think that the research I do that's focused on people's quality of life and outcomes and experiences of health systems is really inspired by my nursing training. So I'm grateful to Lenore and Juliette and others for that. So I'm going to move on and touch on what we mean by public health. So I know a lot of you in the room know that what we mean very, very clearly, but perhaps some of you don't. Donald Aitchison's defined public health as the art and science of preventing disease, and I always want to add the word injury, promoting health and prolonging life through the organised efforts of society. In public health, we're interested in stopping our people from becoming sick in the first place, for example, through healthy environments and waterways, through safe roads and workplaces, or through vaccination campaigns to prevent measles or other infectious diseases, or improved alcohol sale and purchase policies. But when people do experience illness or injury, public health then focuses on how to contain the outbreak or lessen future injuries, and on how we can hasten the recovery process by supporting people to access the necessary health and social services. Of course, health professionals working in the care of individual patients in our healthcare system are crucial to both the recovery process and prolonging life, as those of us who have ever been ill, be this through food poisoning, renal failure, and I see Rob sitting up there in the background, a cardiac or cancer diagnosis or injury, well know. But key to public health is its links to the health of populations. And by this, we can think countries, regions, communities. Public health is not primarily focused on the health of an individual person in front of an individual health professional. At times, public health professionals and researchers are very interested in the health of specific individuals. And I've got here a map of John Snow's diagram recording the deaths of the 1850s cholera epidemics in London and making the connection between affected individuals and the wider reach of the cholera epidemic. And I'd just like to take the liberty of reading a little piece here written about the cholera epidemic at the time, if I can find the right page. So they're talking about Spitalfields, a dust heap in the heart of the East End, a heap of dung the size of a tolerably large house, and an artificial pond into which the contents of cesspits are thrown. The contents are allowed to desiccate in the open air, and they're frequently stirred for that purpose. Mayhew described this grotesque scene in an article published in the London Morning Chronicle in 1849 that surveyed the ground zero of that year's cholera outbreak. We then journeyed onto London Street. Number 1 of this street, the cholera first appeared 17 years ago, so they're talking about the second large epidemic, and spread up it with fearful virulence. But this year it appeared at the opposite end and ran down it with like severity. As we passed along the reeking banks of the sewer, the sun shone upon a narrow slip of water. In the bright light, it appeared the colour of strong green tea and positively looked as solid as black marble in the shadow. Indeed, it was more like watery mud than muddy water, and yet we were assured this was the only water the wretched inhabitants had to drink. As we gazed in horror at it, we saw drains and sewers emptying their filthy contents into it. We saw a whole tier of doorless privies in the open road, common to men and women, built over it. We heard bucket after bucket of filth splash into it, and the limbs of the vagrant boys bathing in it seemed by pure force of contrast as white as marble. And yet as we stood doubting the fearful statement, we saw a little child from one of the galleries opposite lower a tin can with a rope to fill a large bucket that stood beside her. In each of the balconies that hung over the stream, the self-same tub was to be seen in which the inhabitants put the mucky liquid to stand, so that they may, after it has rested for a day or two, skim the fluid from the solid particles of filth and pollution and disease. As the little thing dangled her tin cup as gently as possible into the stream, a bucket of night soil was poured down from the next gallery. And so we have London in 1849 and the great work of John Snow and also Henry Whitehead. This is a very, very good book. If you've not read it, it's called The Ghost Map by Stephen Johnson. And it provides a very good history of the epidemic. And John Snow was able to describe the houses in which the deaths had occurred. And Henry Whitehead, because he was a Presbyterian minister, was able to actually track down the people who had survived the epidemic and moved away. And together they provided some of the solutions to the solving of the cholera problem, although the story of the pump handle at Broad Street's a bit apocryphal, I believe. So what besides health promotion, illness and injury prevention and hastening recovery can we identify as characteristics of public health practice and academia? The key is included in Aitchison's definition. It is public health focused on the organised efforts of society that are the difference. In public health, we're interested in big issues. We're interested in improvements in the health of our populations through action and collective change. We're interested in influencing upstream the social, policy, system sources to reduce the number of people affected downstream, and using the cholera epidemic, thinking about how the knowledge about the behaviours and deaths of individuals can be used to take upstream action for improved drinking water quality, thereby preventing the deaths of thousands. While in public health research, we often learn from the experiences of individuals experiencing health problems, injury, disability, racism, or poverty, we aim to turn that knowledge into generating findings about how to prevent adverse experiences and outcomes for others, and to improve the overall health of our communities. Public health is, at heart, deliberately inclusive of our communities. Often, indeed usually, we have people from our communities directly involved in our research projects. Public health, focused on improving the health of populations through collective social action, is necessarily multidisciplinary. This photo board represents just some of my colleagues from Preventive and Social Medicine, which is one of the largest departments in the university with over 130 staff. Among my colleagues, there are people with particular expertise in certain disciplines. There are Māori health researchers, including the people highlighted here from the Ngāi Tahu Māori Health Research Unit. There are epidemiologists, biostatisticians and data managers, health economists. I know Trudy looks all on her own there, but Trudy does a lot of work with Paul, who's sitting beside her from the Department of Economics, and other biostatisticians, and with us. And a lot of qualified health professionals, including a number of doctors. Aside from disciplinary expertise, there are also groups of people focused on particular topics. For example, cancer, or those of us from our Injury Prevention Research Unit who are focused on injury prevention and rehabilitation. My specific area of public health research is known as health services research. And this means that I focus on considering how people access systems, their process through those systems, social and financial costs, equity and outcomes across a range of populations, illness and injury types. So my public health research career began with a study of people on surgical waiting lists for elective as opposed to acute hip or knee or prostate surgery, supervised by Professor Charlotte Paul, Dr. Jenny Morris, and statistically by Professor Peter Herbison. Meanwhile, a new approach was introduced in the mid-90s, an approach that became known as the booking system, where people were referred to specialists working in our publicly funded hospitals for surgical assessments, and they were then scored and then either granted or denied access to surgery based on that summed score. My PhD focused on that. I was supervised again by Charlotte and Peter and Professor Robin Gould, who's here with us tonight, focused on understanding that new booking system. That research found that people wanted those worse than them to have access ahead of them. That is, people tend to be reasonable. That people preferred to delay surgery until it was really necessary. That is, they were not all breaking down the doors to access theatre and to have operations. But when people really were in need, we needed a better approach to fairly and equitably determine priority. I proposed an alternative approach where firstly specialists would determine whether or not surgery is clinically warranted, and then to effectively prioritise access to surgery according to people's own symptoms. Because importantly, we found that people's own self-reported severity was the best predictor of outcomes following elective surgery, not the clinical priority assessment tools that were being used. Unfortunately, even within our own well-founded healthcare system, changes such as the booking system, which was a multi-million-dollar investment to genuinely try and address the identified problems that existed with waiting lists, are often implemented without a robust evaluation or without even a careful consideration of perverse incentives that could result from such a large-scale system change. The perverse reality of the mid-1990s booking system, and the legacy of which we are left with today, is that each region throughout New Zealand was incentivised to develop their own scoring tools, so we had no national consistency. The development was doctor-driven, with little to no genuine consultation with the people directly affected. And my research found that the criteria that may be important for clinicians deciding whether or not surgery is necessary, which is really important, were not the best criteria for prioritising access if we're interested in improved outcomes for patients. Hence the recommendation that elective surgery first should have clinicians determining the clinical necessity for that treatment, but then that prioritisation should be according to the severity experienced by patients. The other interesting finding from this PhD work was the evident conflict of interest encountered by patients in New Zealand's two-tiered system, whereby elective surgery is provided both by the state or publicly funded hospitals and private hospitals. Although our publicly funded system ranks well in terms of per capita costs, and although, as you can see from this orange bar, 80% of our health services are funded via the taxpayer, we do not rank well in terms of equity in New Zealand. We have a system where the wealthy and privately insured can access treatment with much lesser need for treatment and more quickly than can be provided in the publicly funded healthcare system. Often, the clinicians working in New Zealand's private and public health sectors are the very same people. And there's been no clear effort made to manage the process of clinicians working in both the private and public sectors in New Zealand, with the likely conflict of interests arising as a consequence. Indeed, study participants reported being told by clinicians that they would never receive surgery in the public sector, but that they could operate on them next week in the private hospital, even in cases where their scoring clearly indicates that they would have met the threshold for funded surgery in the public system. Sometimes in our communities, there's an argument that runs something like this, that it's better for us to have a private healthcare system running alongside our publicly funded taxpayer system, because then the wealthy pay privately for treatment. They're then freeing up capacity in the public system for people who can't afford such private treatment. More recently, we undertook research to examine the relationship between the provision of private surgery and access to public treatment, and we found the opposite to be the case. We found wide variations in rates of elective surgery throughout New Zealand, variations not able to be explained by age or other demographic features. And we found that in regions where the private surgery rates were the highest, the publicly funded rates were lower. And even for the poorest New Zealanders, they were most poorly served in the regions where the provision of private surgery was the highest. The implication being that in an unregulated private sector, this does not appear to have a positive effect on equity of elective surgery provision, either geographically or for the most socioeconomically deprived. And the argument that private provision for the wealthy reduces the burden on the public system and allows better access for the poor is not supported. The work of Jeff Fougere, building on Hirschman's work and presented in his book, Exit, Voice and Loyalty, points to the importance of maintaining the integrity of our publicly funded healthcare system, that we need the voices of the educated and wealthy to remain loyal to our publicly funded healthcare system to help advocate for improvements. We do not benefit by those people becoming disenchanted with the public system and exiting that system to go to the private sector if they take with them their loyalty and voices calling for improvement. There's mounting evidence we are all, rich and poor alike, better served by living in a country that holds fast to the vision of a universally accessible healthcare system. Our health system was designed with important core principles, including universal accessibility and equity, and our system here in New Zealand preceded that in England's NHS by a decade. I'm very hopeful that the review of the New Zealand health and disability sector that's now underway will identify solutions to our workforce shortage in the publicly funded health system, and also strategies to help address the evident inequities resulting from an unconstrained private sector. So on completion of my PhD, I moved to the Centre for Health Planning and Management at Keele University, so slightly more contemporary now, we're in 2001. I worked for a number of years at the Centre for Health Planning and Management, worked with a demand management team in the English NHS, and undertook a number of studies, including participatory qualitative research focused on parents' perceptions of needs of health services for children with complex neurological disability. I returned to Dunedin with Brian and Micaiah in mid-2005 and began work at the Injury Prevention Research Unit. My interest in quality of life, equity, and people's processes through the health and social care systems remained constant, but the focus was now more on the condition of injury. In 1746, Lord Chesterfield said this of injury: an injury is much sooner forgotten than an insult, and so it was my job then to investigate whether or not that was true. But there was an ancestral connection for me also with injury. It had been important in my early family, as it has been no doubt in many of yours. This man is my father's great-grandfather and namesake Micaiah Reid. So Micaiah Reid had worked as an early policeman at the Crystal Palace exhibition in London in 1851. And then in 1857, he travelled with his wife Louisa and their 6 children to Wellington, where he became the first governor of the Wellington jail from 1860 to 1865. And we're proud of him for opposing the death penalty. Unfortunately, had to witness a lot of executions in his role as governor of the jail. But in 1886, so here's the Crystal Palace. But in 1886, the newspaper reported he was driving his phaeton down Tory Street in the direction of Courtney Place when his horse became frightened and bolted and came into collision with a butcher's cart. The shock was so great that Mr. Reid was shot up in the air and came down on a wooden crossing with great violence, and he suffered severe injuries to his head. He then required considerable care from his wife Louisa and family until he eventually died 3 years later. Micaiah's outcome ended in being finite, sadly for our family, and we can only imagine how challenging it must have been for him and his immediate family in the time between the injury event itself and his passing. Perhaps surprisingly, well, it was surprising to me, very little is known either nationally or internationally about people's quality of life or experiences post-injury if they weren't killed by the injury event. So at IPRU, I worked on developing what became known as the Prospective Outcomes of Injury Study, or POIS for short. This study was funded by the Health Research Council with co-funding from ACC, and the pilot in POIS ran from 2006 to 2013. And because the study is so comprehensive, we're still publishing findings from POIS. And there are a number of interesting features. We recruited from 5 regions throughout New Zealand and ensured that 20% of the cohort were Māori, so that Māori-specific analyses could be undertaken. Poise was necessary public health research for a number of reasons. For example, injury affects many of us and it's expensive. Last year, New Zealand's no-fault injury insurer, the Accident Compensation Corporation, received almost 2 million claims from injured New Zealanders for treatment and spent $4.9 billion supporting injured people in New Zealand. That's just in 1 year, $4.9 billion. And there are a number of aspects to the Poise study that our team is, I believe, rightly proud of. First and foremost, Poise was designed with 2 Māori co-investigators, Dr. Brendan Hokowhitu, now Dean at Waikato, and Dr. Emma Wyeth, now Director of the Ngāi Tahu Māori Health Research Unit in Preventive and Social Medicine. In designing Poise, we consulted with and listened to Māori kaumātua in the 5 study regions about how the study should operate, how we should collect the data and analyse that data, and we've written a paper describing that process. Dr. Wyeth has since led the analyses reporting on the outcomes for injured Māori informed by Māori theories of health and well-being. So thinking about people, power and policy, we engaged with people. Power came about in our listening to Māori advisors and taking that advice very seriously and changing the design of our study as a consequence. Acting on this advice has meant Poise has been able to deliver findings of relevance to Māori and communities in New Zealand. Another important aspect of Poise has been in considering the relationships between work, injury and outcome. 1/3 of our injured Poise participants were injured in the workplace, cuts, crushes, falls, even assaults. Our ACC earnings-related compensation means that people are entitled to up to 80% of their pre-injury income while rehabilitating from injury. There has been, in general thinking, the idea that many people will use an injury event as a reason to unreasonably linger on ACC while waiting, just watching 80% of their income rolling in. Such thinking, albeit not based on empirical evidence, can influence policy. So Poise was able to investigate this assumption, so with John, Rebecca, Ari and myself, by considering whether or not people had returned to paid employment in relation to the level of disability they were experiencing. We found indeed that 8% of Poise participants who were working before their injury had not returned to sustained paid employment 1 year post-injury. However, we found that 3/4 of these people, 3/4 of that 8%, had profound disability, leaving only 2% who had not returned to paid employment and had no profound disability. Meanwhile, also, the economic recession had bitten, so rather than thinking that 2% were malingering, we think it's possible that 2%, actually it's 1.6%, were going through redundancy or were looking for other paid employment opportunities at the time. The policy implications of this are significant. When looking at indicators of success of rehabilitation programs, ACC and government should look to assess other indicators of outcomes, such as disability. And indeed, we've been told by ACC that Poise has informed their focus on how they can better assess outcomes. We also looked at what factors predicted not working post-injury. Although there were some individual level factors, such as having a number of other conditions or comorbidities, there were broader social factors that warranted our attention. People on low incomes, people dissatisfied with their work, and people on temporary or fixed-term contracts all experienced disadvantage in terms of returning to paid employment post-injury. These are factors that we as a society can and should address. Healthy workplaces, humane conditions of employment, and living wages are achievable, and the recent important steps in moving the minimum wage to a living wage in the health sector are a significant acknowledgement of this. From our qualitative research in Poise, we've heard in people's own words the experience of the person with an extremely serious workplace injury being told by their employer on their hospital bed that they no longer had a job to return to, i.e. you're sacked, compared to the person whose employer supported them every step of the way to recovery, reassuring them throughout that their job is being held for them and that every accommodation will be made to help them return to work. These differences matter, but to effect change, we need much more legislative support to nudge the poor employer towards the behaviour of the good. And there are implications for us from our Poise research in our own workplace here at the university, where we've been going through considerable changes for our professional administrative staff. There have been positive changes and new opportunities for some, but also painful changes for those made redundant, being moved away from departments where they'd worked for years to other parts of the university, or having their jobs downgraded to a lower level and pay scale. We have responsibilities as colleagues and students of our university to consider job satisfaction as an important part of people's working environment and to avoid reducing people to sets of transferable skills. Instead, our POISE research suggests it's important for us to recognise employees' relationships and histories, and to recognise people's long-standing commitment to the successful functioning of our university. Awareness of the need to focus on people and context has been available to us for many years. For example, Viktor Frankl, reflecting on his years in a concentration camp, has written about the importance of relationships in man's search for meaning. And Hannah Arendt, in The Origins of Totalitarianism, wrote about the risks associated with regarding people as sets of labour skills, and of people feeling disconnected from relationships and the sense of identity those connections bring. Their messages are as relevant to us now in the 21st century as they were in post-World War II. Another important piece of work from POISE was the empirical investigation of the differences between those who have had a serious injury and those who have had a serious illness, an issue that's been of interest to many of us in public health for some years. For her PhD research, Sue McAllister, who's here in the audience, was able to compare the outcomes for a matched sample of injured POISE participants receiving 80% of their income from ACC with the outcomes for those in the same age group who'd had a stroke. The study found considerable differences between the injury group, which had ACC cover, and the group experiencing stroke, both in loss of income, so you can see a 13% decline in income for those who had ACC cover, but a 60% decline in income for the same age group, matched sample, but group of people who'd had a stroke instead, a 60% decline in income for that group, and lower rates of return to paid employment for the group affected by stroke, only 49% getting back to work compared to 79% with the same level of functional impairment, but that had an injury and they had a lot of support from ACC to help them return to work. And similarly, analysis from the spinal cord injury study led by Dr. Martin Sullivan in this picture here found similar findings. So again, we saw the group that was entitled to ACC cover because their spinal cord injury resulted from an injury event. Much more of them got back to work compared to those whose spinal cord impairment resulted from an illness such as a hemorrhage or a spinal stenosis. A much smaller proportion got back to work. Again, addressing such inequities is something that's within our society's grasp. We need to consider as a country whether or not we're content with individuals and their whānau falling into poverty as a consequence of serious illness, while evidence demonstrates the improved outcomes for those with an injury who received adequate support. So Owen Woodhouse, who led the Royal Commission of Inquiry and whose recommendations led to the introduction of ACC, which is the system that's the envy of many countries throughout the world, always envisaged that ACC would be extended to provide support for those with serious illness. And our research strengthens calls that the time to address this evident need has arrived. And so last but certainly not least, I'm going to talk about service. So as Professor Blakey said, you know, in academia, those of us who teach, our lives are sort of allocated proportions of time, 40% teaching, 40% research, and 20% service. So I'm going to spend a bit of time talking about service. Service can be sitting on various academic committees, journal editorial roles, but for many of us in public health and other disciplines here at Otago, it involves working in our communities. And this is my community. This is one of Brian's lovely panoramas of Port Chalmers. And I've been a member of the board of the Kopatai Lodge, a facility that provides residential care for people with mental health conditions for a number of years. It's based in Port Chalmers, or Kopatai, and has wonderful leadership from a mana who lives locally, and most of the staff who work there also live locally. The engagement of residents in the functioning of Kopatai Lodge is key. One resident sits on the board, and all of these things help make Kopatai the place it is. But thinking back to the importance of our recognising professional administrative staff within the context of relationships here at Otago, I think it's the place of kōputai in the community of Port Chalmers that benefits all of us who live there. The residents are recognised and valued as members of our community with their interests, knowledge and skills. But I believe the real benefit comes from the recognition that we in Port Chalmers are lucky enough to live in a community that cares for our people and people who oftentimes have very great need. Another service role for me has been as an active member of Bowel Cancer New Zealand. I honestly don't believe that I recognise the positives of being diagnosed with stage 3 bowel cancer at the age of 39, but as it turns out, there were some positives. Of course, I cannot thank Brian, Makaya, my parents, colleagues and friends enough for the support offered to me at that time, and also to the excellent healthcare I received that's led to my still being here 14 years on. But the positives arose as a consequence really under the inspiration of Professor David Perez, a local oncologist, who called together a meeting of a group of patients and whānau affected by bowel cancer in New Zealand in 2009. And from that initial meeting, we went on to form Bowel Cancer New Zealand, which is a patient and family-led charity which has the goal of reducing the impact of bowel cancer on our communities through raising awareness, education, support, and research. Because back in 2009, it seems hard to believe, but there really was very little awareness of bowel cancer in New Zealand. As a group of volunteers, we've worked hard to raise awareness and change that, so that by now I hope that many of you are aware that 3,000 New Zealanders are diagnosed each and every year of bowel cancer, and that sadly 1,200 New Zealanders will pass away as a consequence of that diagnosis. I hope that many of you know that as many women will die from bowel cancer as die from breast cancer, and that as many men will die from bowel cancer as die from prostate cancer. And also, and importantly, that 300 people under the age of 50 are diagnosed each and every year, people as young as teenagers. Now it's a decade since we first formed, and we're beginning to see a national screening program implemented throughout New Zealand. This is excellent news, but there's a long way to go, and Bowel Cancer New Zealand's working harder than ever with a small part-time staff to ensure that work continues. And we move from being recognised from having our world worst bowel cancer statistics to a country that has a world-leading screening program in place. And the last component of service I wish to acknowledge before wrapping up is the Community Health Council, which formed as an advisory group to the Southern District Health Board and WellSouth PHO in December 2016. I've been fortunate enough to be the establishment chair of the Community Health Council, which includes 11 people from throughout the Southern Health Region system who bring with them their community networks in areas of interest, ranging from mental health and men's health, and I think I saw Martin here before who champions that. You can see the people's names underneath. Through to Hauora Māori, we've got Kelly Takarua from Tapanui and Matahaere here from Dunedin. Pacific Health, we've got Hana Halalele from Oamaru. Younger People's Health with Rosa Flaherty, also bringing her interests in the LGBTQ+ community. Older People's Health with Leslie Day from Invercargill. And Women's Health and Disabled Persons Health with Paula Waby, who's here tonight. So these people have come together as a group to provide advice, to inform Ian's WellSouth PHO and the DHB about how to improve our healthcare system. But what's been key to that is recognising that as a group of 11 people, we can't do that. And so one of the most significant pieces of work the Community Health Council's been doing has been to develop a framework and to implement a roadmap to widen the pool of people who are interested in being advisors to the healthcare system. And so far we have over 50 people who've expressed interest in being an advisor to the system, and over 20, I think it's in the high 20s, actively involved in working on specific projects throughout our healthcare system to bring that important be it patient, whānau, community expertise, to what the system needs to improve. And so if any of you are interested in participating in that program, I encourage you to contact our exceptional advisor, Charlotte Dank, who's on the right-hand side of the picture in the yellow cardigan, and participate. So I'd like to end my talk by acknowledging the importance of values accompanying our national healthcare system, introduced over 80 years ago, or 80 years ago exactly, actually, in 1938. It was aspirationally stated that it's the inalienable right of every person to be secured against distress, for after all, the people's well-being is the highest law. Public health research can help illustrate whether or not such aspirational goals have been realised. I would argue that we're not quite there yet, but if we all, in our various ways, be it through research, writing, art, music, gardening, our conversations with people in our communities, we endeavour to participate in change and work in partnership with others to do so, we're capable of placing people's well-being uppermost, which is a shared goal of most, if not all of us working in public health. Thank you.
Kia ora koutou. I'm Trish Priest. I'm the Head of Department of Preventive and Social Medicine. And it's my job to propose a vote of thanks to Sarah for her really interesting talk. It's one of the other great things about coming to these talks is that you learn things about your colleagues that you didn't know. So thank you for your exposition on your past and your ancestry. It's fascinating. Professor Sarah Derrett has a long association with the Department of Preventive and Social Medicine, having had 3 stints with us, 1 as a student and 2 as employees. And we're really delighted to be able to congratulate her on her promotion. Sarah's title, Public Health and Communities, People, Power and Policy, is a great summary of the breadth of her work and her choice to work in a multidisciplinary way in a very multidisciplinary area. At the heart of Sarah's talk and work is her concern for people, their health, the importance of their engagement in research in health services and in the development of health policy. Her international expertise, which she didn't talk a lot about in patient-reported outcomes, is an example which arose from her PhD research, and which her PhD research also supported and informed her passion for work on equity. Her work on injury, as she said, is also informed by her concern for people, their empowerment and health, and underpinned by principles of equity, fairness, and system approaches. Sarah exemplifies the engaged academic. She not only does research into how health services can best be delivered, she's actively involved in advocating for good services, working with and on behalf of groups of patients and the public. And I just wanted to highlight the fact, as she just mentioned, that in taking on the role of chair of the Community Health Council, which was something, as her head of department, I can say, frankly, she didn't need in her life because she's very, very busy in all her other things. But she took on that role and made a point of developing a framework to increase the engagement of members of the communities to improve the Southern health system. Many of us in this room went into health and public health because we wanted to make the world a better place, including through improving equity. Sarah's work is an inspiration to academics, perhaps particularly, but by no means exclusively, public health academics, to get out of the academy and work with communities, work with people as research participants, patients, citizens, to achieve that aim of making the world a better place. That's Sarah's challenge to all of us, and I, for one, feel challenged, and will do my best to think about how I can do better on that, and I really encourage you all to. We at Preventive and Social Medicine are lucky and proud to have Sarah as a member of our staff, and I'm absolutely delighted to congratulate on her on her promotion and to celebrate with her. And I have a small gift to acknowledge her promotion and her talk. Thank you. And I'll now invite you to join us at the Staff Club for a function to celebrate Sarah's professorialness. Thanks.